Why is that? Why do you think it's the universal donor? O negative. There's no surface antigens, right? So as long as you separate it from its antibodies, which is in the plasma, there's nothing that will cause a response in the recipient, right? Because O negative, it's going to make antibodies to everything else, right? So it's going to have antibodies against type A, against type AB, against type B, against Rh positive. So it's going to have all those antibodies to attack everything else. But as long as it's separated, the plasma from the red blood cells, and you're just giving pure O negative red blood cells with no antibodies, then it can be given to anybody.
So do they just reconstitute that in normal saline, or do they go to plasma through something like AB?
So the red blood cells, it is in a solution because in separating it from the plasma, we also separate it from the platelets, right? So we try to make it so that blood isn't going to clot off in the bag while it's waiting to go to somebody. So it's separated from all its platelet factors as well, so it's not going to clot off. Let's see. Give me your question again.
So you have the formed element of the blood cell.
Uh-huh.
Is it just combined with saline and then stored, or?
Right. Yeah. So it's combined with a solution, pretty much like saline, so that there's not an osmotic effect with those red blood cells, right? Because if there's an osmotic effect, it can cause the red blood cells to swell or shrink. So it just has to be in a solution that has the same ionic composition as those red blood cells in and out, so there's not any change to the shape of that red blood cell. But yeah.
And then what about like with plasma? If it's given to a recipient, have those antibodies been removed from the plasma as well?
Right. Yes. So if plasma, if we're giving a patient plasma, we remove those antibodies or match them. But for the most part, plasma is pretty universal. So all those antibodies are removed, and plasma is given mostly for volume, but also as a balancing act. So when a patient has huge blood loss, you can't just give them red blood cells, right? Or the site where they're bleeding from will bleed worse. You have to give them clotting factors, so you have to give them platelets, and then the clotting factors are all in the plasma. So the platelets themselves don't have those clotting factors. The clotting factors are in the plasma. So you have to give red blood cells, plasma, and platelets all together in a pretty equal ratio in order to, one, improve the volume of the patient, right, to give them more red blood cells, but also don't worsen the bleeding. That's oftentimes where, if somebody has a really bad GI bleed, if you give them too much red blood cells without the other stuff, they'll bleed worse, and you'll worsen the problem. So there's a lot of recent research that say in GI bleeds, if their if their blood pressure is okay, even if it's a little bit low, but if it's not organ failure blood pressure, don't give them anything until we can actually fix the problem.
So those clotting factors that make it so hard to synthesize synthetic plasma effect?
No, it's partly with the clotting factors, but it's mostly because of the soluble proteins, because those are changing so much in the body. So the composition is just really hard to match.
What if they got like a sample of plasma and they match the albumins and globulins?
Well, those are the main proteins, so albumins and globulins, but they're also attached to, because they specialize. They're there basically to attach to other molecules to help with transport in and out of the bloodstream. So there's an infinite amount of different proteins that they're attached to and combined with to make up the composition. So it's a really generic plasma, but it's not a match just because it would be so individualized. So what's the universal receiver then? Person that can receive anything. AB positive, right? And why is that? Why can they get everything? Yeah, because They've got all of the antigens, so they don't have any of the antibodies that are going to attack the donor, right? Good. All right. Let's see. So the heart, this is the longest lecture, and we'll try to get into the details of the heart. This one, I think if anything you learned today from a practical standpoint is the most important. If you can understand the physiology of the heart, you're going to be that much better in treating everything. Hypotension, hypertension, hypovolemia, all of the medications that you're giving to either increase blood pressure, decrease blood pressure, increase contractility of the heart, help with heart attacks, all of that stuff, which is a huge chunk of meat of what you guys do is involved with the heart, especially the bad stuff that you get in what you do. So this is kind of the general topics that we're going to address here. The circulatory system, the anatomy, how the heart beats, and then the dynamics of how that beat works. So muscular organ, I mean, this is just kind of cool facts. Beats 100,000 times a day, and in one day it will go through 8 liters of blood. So I mean, that thing is just a used muscle, right? It's amazing that it lasts as long as it does. I mean, we talk about all of the mechanical things that we build and how long they can last, but I mean, this thing is non-stop all the time, and it lasts for 100 years sometimes. It's just crazy. So heart's place in the circulatory system. Obviously, it's the pump, right? Okay. Main thing with circulatory system is just breaking it down. So there's the pulmonary circuit and systemic circuit, and it can get a little bit tricky in just identifying what is an artery or vein, especially in the pulmonary system because it switches, right? And this is a picture that can kind of explain that with the pulmonary circuit. So real quick, let's just draw, because I think that sometimes that picture can be a little bit messy. So if you got the 4 chambers of the heart and you're just staring at the heart, right? What are these 4 chambers? What's this one? Good. Right atrium, left atrium, right ventricle, and left ventricle, right? Okay, so blood from the body is returning to the heart where? Right atrium, good. And then blood from the right atrium to the right ventricle, right? And then that right ventricle goes to where? The lungs, right? And I apologize, I'm not left-handed. And then from the lungs it goes where? Left atrium, then left atrium to the left ventricle out, right? So there's your process. But everything from the body going back to the heart is through what? What kind of vessel? A vein, right? Everything from the heart to the body is a artery. But from the right ventricle to the lungs, so leaving the heart, it's an artery, right? So that's the switch. Leaving the heart to the body is an artery. Leaving the heart to the lungs is still an artery. The lungs to the left atrium is what? Pulmonary vein. Good. All right. So we talked about 4 chambers and the circuit involved in the 4 chambers. And we talked about, we already kind of went through this. Right atrium receives the blood, right ventricle kicks it out into the pulmonary artery. Left atrium gets the blood from the lungs and then kick out into the body from the left ventricle. The difference here in composition is deoxygenated and oxygenated blood, right? Because it switches. Mostly oxygenated blood is in which kind of vessel? Artery or vein? Artery, right? But here in the pulmonary artery, what kind of blood is that? Deoxygenated. So that's those are the only arteries where it's deoxygenated. Otherwise, arteries are always oxygenated. Good. So
Question on that real quick.
Yeah.
So as far as the anatomy of those arteries and veins, pulmonary artery and veins, I guess are they switched? I mean, wouldn't the pulmonary artery resemble more of a vein? And it's going to be thinner. It's not going to be as muscle.
Right. It's different in and of itself. One, because of the size, but also just because of the forces involved. Because it's receiving blood from a right ventricle all the time. It's pumping at a certain pressure. So even though it has deoxygenated blood and you think that it would resemble more of a vein, it's pretty muscular because it has to put up with a lot of stress. All right. So it has a very strong tunica externum. We'll talk about that. That's an outer layer of those vessels. But it also has a pretty robust muscular layer with the tunica media. So the heart is in the mediastinum. It is held in the mediastinum by connective tissues, right? And we'll talk about the pericardium a little bit as well. But also in the mediastinum is the thymus, esophagus, and trachea. That's all part of a very similar cavity. That's why sometimes neck infections can go down into the chest. It's because they're connected in the same cavities. Let's see. So this is the pericardial cavity. This is where the pericardium is, and there's an outer layer of the pericardium and an inner layer, right? So the inner layer is right on top of the heart. That's called the visceral pericardium. And then the outer layer is the epicardium, and the fluid in between those two layers is just kind of a matrix. You can think of it as almost like oil that keeps everything moving, because that heart is constantly moving. It's not in a fixed spot because it's always beating, right? There has to be some give. So that's why you have that fluid chamber with the pericardium around the heart. And that's why in circumstances where you've got blood leaking into the pericardium or excess fluid in the pericardium, it becomes a barrier, and the heart can't pump effectively because it can't dilate against too much fluid, and that's where tamponade comes from, right? Can't dilate enough, can't receive enough blood, which means it can't pump out enough blood, and you get tamponade. Decreases blood pressure, and people can die if that gets too bad. And in certain circumstances, very rare, you get to stick a needle into the pericardium and drain that fluid. It's awesome, right?
Does it ever start to clot in there?
Yeah, it does.
Cut it open.
It can start to clot. So old blood will start to clot. But generally, life threatening pericardial fluid is acute, because old stuff is usually, it's not a constant bleed. It's kind of a slower process, and you'll get clotted blood. But new blood generally can be drained because it's more acute. So if you, we talked about this a little bit already, but if you can imagine that fist being like the heart, and this is the different layers of the pericardium surrounding the heart with that pericardial sac. And we talked about this as well. It's just kind of a collagen network. And if you can think about the pericardium, it also attaches to the mediastinum to keep the heart in a relative still location, so it's not falling anywhere, and it can support all of that movement, all of that blood going from the aorta that that collagen network is almost kind of like you think of ligaments holding bones together. This is like the ligament of the heart that holds it in place. Pericardial cavity. This is just the space inside the mediastinum in between the heart and the lungs. Yeah, and like we talked about before, it acts as a lubricant for all of that movement going on. So yeah, the heart sits at an angle. It's kind of rotated to the left, so that if you were to stab the heart from the chest, you'd be stabbing what most likely? Right atrium or right ventricle. Good, because of that rotation and that. The left ventricle, which is the larger, more muscular ventricle, is kind of rotated in the posterior, so it's really protected. Oh, okay. So these are just the muscle layers of the heart. We've got the epicardium, myocardium, endocardium. Myocardium is the big muscular layer where most of the magic happens. Epicardium, just like the pericardium, is the outer layer. Epi is always going to be outer. It's where the heart is attached by those connective tissues to stabilize it. Myocardium is the muscular layer. This is where blood vessels are as well. This is where the nerves are, because this is where the electrical system has to happen in the heart to get a contraction, right? And we'll talk about that later. The electrical system of the heart is pretty incredible as well, and how it all works. So it kind of wraps around the heart in a very specific way. It's circular around the atrium, and then it spirals around the ventricles. And there's a reason for that, which enables the heart to squeeze a very specific way, to squeeze from the bottom up in a spiral motion to get the most efficient contraction and squeeze to get blood out, right? So this shows kind of a picture of how those muscles work. The atrium is just that circular because all it's doing is kind of condensing that space, push blood down into the ventricle, but it doesn't have to be, super hard squeeze. It's already following gravity for the most part. But the spiral motion of the ventricles is really cool in that it kind of wrings the heart, almost like when you're wringing a towel to get the most fluid out of that towel. That heart is kind of twisting in its contraction to be able to squeeze the most blood out of that chamber. Endocardium is the most inner surface. That's where your squamous epithelium is. Let's see.
So when the heart contracts, is there any inside of the chambers? Is there any residual blood left over, or is all of the blood sufficiently moved to the next chamber?
It depends on your heart, and everybody's heart is a little bit different. Just about everybody, nobody has complete, expulsion of blood from any chamber. There is going to be some residual, but like with the left ventricle, for instance, it's pretty little. It's just like surface stuff. If you were to dump out a container of oil or whatever, because if you can think of blood, if you've ever, really felt the consistency of blood, it's viscous and it feels oily. And same thing, like if you were to dump out a container, you'd still have kind of some residual oil left, even though it's basically empty. To get all of it, you have to sit there and wait for gravity to do everything. But it's a pretty effective pump. There's residual on the surface of that endothelium, but like I said, it's a very, very effective and efficient pump designed very specifically to do its job. So the muscle cells, smaller than skeletal muscle fibers, especially in length. As you can see, you've got these points, and there's a nucleus. You can see that's one muscle fiber, that's one muscle fiber, or at least a muscle cell, I should say. There's multiple muscle fibers inside fibrils, but that's one muscle cell as well. And they're shorter. Where skeletal muscle, I mean, a cell can be pretty long, almost the length of the muscle. But in the heart, they're very short. And that has to do with the electrical system and how it contracts and to get the most out of that. And these are, these points in between are sarcomeres. But so each muscle cell contains myofibrils, and that's these strands that kind of are going across. And they have muscle cells have an enormous amount of mitochondria. Why do you think that is? Right, mitochondria is where the cell gets a lot of energy. So they contain a lot of mitochondria, and let's see, abundant reserves of myoglobin, obviously, to store oxygen for times when you're hypoxia. The heart can keep going at least for a little while with those oxygen stores. It also reserves glycogen and lipids to get energy, but it's mostly an aerobic system. It needs oxygen. It can't work under an anaerobic system. It doesn't work well with lactic acid, right?
So we get sodium bicarb in cardiac machines. What's the interaction between sodium bicarb and lactic acid?
Why do you think you give sodium bicarb in a rest?
The balance of lactic acid.
So true, it acts as a buffer, so it improves acidosis. But in a cardiac arrest, you're not necessarily giving bicarb to save the patient from acidosis, although that is a function. It does do, if your lactic acid is 12 or whatever, you got to give bicarb to try to stabilize that, so the patient isn't acidotic, because you have to maintain the pH, right? It's one of the functions of blood is to maintain that pH. But you also are giving bicarb not only to balance the acidosis, but you're giving bicarb because you don't know what caused that arrest, and a possibility is hyperkalemia or high potassium, right? And bicarb will decrease the potassium in the bloodstream and push the potassium back into the cells to try to stabilize the heart. Okay?
Is the reaction between lactic acid and sodium bicarbonate, is there a lot of CO2 produced?
Yeah.
So would that further cause more damage?
It can. So that's why ventilation and CPR is so important, because it is going to produce CO2 and you've got to be able to get rid of that. That's why initially when you get a patient back, you get these huge CO2 rises in the capnography because the patient had all of this CO2 built up that it needs to get rid of, and now it's just starting to get rid of it all, and so you get this kind of jump in the capnography. And that also happens when the patient is starting to turn and go down, because it's not getting rid of, at least effectively, that hypercapnia, that CO2. So yeah, that's why ventilation and CPR are so important. The desmosomes basically act to help contraction, help pull those different muscle cells together for effective contraction. The gap junctions are for the electrical system. So the gap junctions help cells communicate with each other to get that pattern of muscle contraction for appropriate, because the atrium is going to contract before the ventricle. The right ventricle is going to contract just barely before the left ventricle. So there's a very specific system in that contraction, and the gap junctions is what allows that electrical connection between the cells. So we talked about this. All the connective tissues help stabilize They both wrap around and stabilize the location of the muscle cells, and they tie everything together to keep all of those different chambers of the heart in place. So it's kind of the skeleton of the heart and those connective tissues. We talked about this. It's kind of more of the same on that slide. So the atrioventricular valves, these are the valves in between the atrium and the ventricles on either side. These valves help prevent backflow. So when they shut and that ventricle is squeezing, you don't want the blood to go back into the atrium. So it prevents backflow. The blood go back into the atrium, so that blood can go out where it's supposed to go, either the lungs or to the rest of the body. But those valves, the AV valves, are connected by chordae tendineae. So when that pump goes back up, that chordae tendineae, when the blood is filling into the ventricle chamber, that chordae tendineae pulls down on those valves, open up so the blood can get from the atrium into the ventricle. Then when it squeezes back out, that chordae tendineae kind of acts as an anchor for that valve. The blood pushes that valve back up to prevent any blood going back into the atrium, and that chordae tendineae prevents prolapse. And that valve can go completely back, right? So it kind of acts as an anchor. So yeah, we talked about that. The AV valve prevents blood go back into the atrium, forces the cuffs together, closes the valve when it's squeezing. So that's part of the anatomy of it. As the blood's filling, it expands that wall, and the chordae tendineae pushes those valves back, or pushing those valves down so the blood can get in. And then when it squeezes, it helps shut that valve and acts as an anchor so the blood can go where it's supposed to go. And this is kind of what I talked about in that last slide, is the tension of the papillary muscles and the chordae tendineae keeps it from prolapsing, and so there's no regurgitation into the atrium. And when a patient has like a mitral valve regurgitation, it's because that valve is bad, so it's allowing blood back into the atrium.
When you get that regurgitation, blood that's going in there, clot.
You can get blood clotting if you're getting significant backflow. But with the contractions and blood moving, it doesn't happen very much unless you have like a significant space for that blood to remain still and clot. But yeah, you can. And that especially can happen in arrests. You know, if that blood is sitting in the heart for too long and not moving, you can get clot. So regurgitation, and that's the murmur that sometimes you can hear, right? This slow going and kind of circling, that blood circling creates that swirling effect, and it creates a murmur that you can hear. The semilunar valves are pulmonary valve and the aortic valve. They do not require chordae tendineae. They don't have to be braced because there's no contraction where those valves are. They're in a fixed place. So they don't need to be braced like the other valves do. A little bit about the semilunar valves is they're 3 symmetrical cusps, and they prevent backflow just because of the way they're shaped and they're made, and they're in a very fixed spot in either the pulmonary artery or the aorta. So they don't need those anchors. These sinuses are just on the sides of these semilunar valves, and they prevent, when it opens up, it prevents the valve from sticking to the walls. There's these little sacs or sinuses that make sure that they don't stick and that they collapse back down when they need to. Let's see. Okay, so we're just getting into the coronary arteries, the actual blood supply to the muscles of the heart and where they come from. So right and left coronary arteries are at the base of the aorta. So just as blood is being pumped through the aorta, you're getting blood going to the coronary arteries. But you also, as soon as that valve stops and there's a little bit of backflow and diastole, there's still blood going to the coronary arteries as well. Coronary arteries need a very certain pressure, and it's a high pressure, and they need continuous blood because that heart is working hard all the time and pumping all the time. It needs blood flow all the time. And that's why those coronary arteries are so important. And they need to maintain a certain blood pressure to get blood flow into the muscle of the heart. Right coronary artery supplies to the right atrium, also supplies to the posterior heart, the right ventricle, and a little bit of the left ventricle as well. And that's why you can get inferior heart attacks or posterior heart attacks that also affect the left ventricle. The left coronary artery supplies obviously the septum and the left ventricle. And as you're looking at the heart straight on, it's that big artery that goes down the middle and supplies that septum and left ventricle. Then we've got the branches of the right coronary artery are the posterior and then the marginal, and the marginal is that anterior branch there. And then it wraps around and it goes to the posterior interventricular branch. Two branches of the coronary artery are circumflex, kind of wrap around and hit the posterior side of that left ventricle, and then the anterior. And that's the kind of, when we talk about the the big heart attack, is the LAD, right? So it's blocking it's a left coronary artery. It blocks both the circumflex and the anterior, and it's that those are your massive heart attacks. So blood is carried through the coronary arteries and then collected with the coronary veins and dumped into the sinus. And that sinus dumps right back into the right atrium. The coronary sinus is a thin-walled vein because it's not receiving great amount of pressure, just like most veins. And like I said, it opens into the right atrium, just near the inferior vena cava. So, blood supply to the heart. An infarct is a heart attack, right? That is decreased blood supply or interruption of blood flow. And then, real quick, when we're talking about plaque buildup in a coronary artery, because this is so much of what you guys do. If you've got an artery and you've got plaque buildup like that on both sides because of high cholesterol, hypertension will cause that muscle to swell and get bigger, and then you've got this smaller area for blood to go, right? Now at rest, that heart might be able to get enough blood flow, even with that plaque buildup. But if you make that heart work even a little bit harder, patients say, oh, I only get pain if I walk, to the mall, or if I'm going out to get my mail, or I was running on the treadmill, and it's because that heart is demanding more blood, and it can't get there because of that black plaque buildup, and that's what angina is pain because of exertion, because of plaque buildup. Now, a clot, some of this stuff can break off and then completely clot off, and then that's your heart attacks at rest, heart attacks during sleep, or heart attacks at any time is because of that clot buildup. So that's kind of the difference in the interruption of blood flow to those coronary arteries. And because the those heart muscles need blood flow so continuously, it doesn't take long for those muscles to start to die if they're not getting the blood flow.
So those atherosclerotic plaque buildup problems, if you change diet over time, stuff like that, does the plaque buildup go away?
Yeah. certainly improve that plaque buildup, and it'll be broken down. It can go away with lifestyle changes. And control the blood pressure. Obviously better diet, and you'll be able to chew into that and improve that. Now there are some atherosclerotic plaques that become hard, and because they're so old from such long bad lifestyle choices, they're a lot more difficult to go away. So sometimes somebody will change their lifestyle and they'll be in good shape, but they can still have heart attacks because it takes a long time for some of those old plaques that become calcified, and it takes a long time for those to go away. So and when you take a patient to a cath lab, that's what they're doing, right? They're snaking the wire up through the artery to get into the left ventricle, or not into the left ventricle, but they're going they're going into the left ventricle, into the right atrium, because they're trying to get to the coronary arteries, right? They snake it. It's amazing that they can even do that and be able to direct that from the outside and get it through everything to get to the coronary arteries, which are right at the base of the aorta, right? They go through the coronary arteries, and they can find the plaques by shooting the dye and looking at the X-ray at the same time. They can find out where those plaques are, and they go in there and they just bust it. So they expand, they have wires, and they expand that plaque and basically crush it back into its the walls of its vessel, the tunica externa, and we'll learn about that later, to open that up. And then to keep it open, sometimes they'll put a stent in. But they don't always have to put a stent in. Sometimes they can just crush it and open it up. Sometimes they need to put a stent in.
So it would be almost like an aneurysm, but what you're saying is it actually the vein in the artery that absorbs that space?
Yep, exactly. So it does it like this is a matrix. The plaque is kind of a matrix, and it has. You can crush it without causing, like what you're saying, without causing an aneurysm. The artery obviously is a robust vessel, has a good muscular layer and everything, and there's space in between all of this. It's not like dense, like cement type. What we're thinking. It's a matrix of for a better term, it's a matrix of fat and cholesterol and whatever, and it can be crushed. There's space for that. So it doesn't create an aneurysm. Of course, that has happened where they crush it and they create an aneurysm, and they have to fix that.
What determines if they're going to go in with a stent or just crush it and call it good?
Sometimes it depends on what they see, how bad, how narrow that space is, what kind of shape the patient's in already. Oftentimes they'll put a stent in regardless. Now, if the patient has hemophilia or a problem where they can't be anticoagulated, or they already have a brain bleed or something like that, and we don't want to give them Plavix on a regular basis, then sometimes they'll not put a stent in. Because if they put a stent in, most of the time they need to give anticoagulants as well, so that they don't clot off blood where the stent is.
How often do they go in with that type of procedure, anticipating to find like one thing and then find several things, or maybe another thing that works?
Right.
How often does that actually happen?
So yeah, based on the EKG, for the most part, we can tell where the infarct should be, right? But sometimes there'll be multiple infarcts, or you go in and say, okay, this is where the injury is, but this other artery is also 95% occluded. We should probably open that back up too. So they'll squirt the dye in like the main branch of the LAD. So it's going through the circumflex, it's going down into the anterior, and they can see where all those narrowings are. And sometimes there'll be multiple on the same vessel. If it's too narrow, they can't even put a stent in, and it's almost like, well, sorry. the body will, if it's a really slow process and you're getting narrowing on in a really slow process, your body will create a collateral flow, and it'll make new vessels to go to those areas. Sometimes people have a total occlusion, but it's been such a slow process, they'll have collateral flow already to the muscle, so it doesn't totally die. But oftentimes, if it's completely occluded, they can't put a stent in. They don't want to bust through it, and, break off cloth. And that's also another risk in doing this. As you're putting that wire through, you can break off cloth, and it can go down and get stuck, and then you're not going to save that muscle.
Are those occlusions only in the heart itself, or those in the arteries leading up?
Yeah, so those occlusions are in the heart, are in the arteries going to the muscle, right? So they're not in the chambers of the heart. They're not in the muscle of the heart. They're in the arteries feeding the muscle of the heart. So let's see. So myocardial infarction, MI. Circulation becomes blocked. Muscle cells die because they're not getting blood flow. They're not getting oxygen. So they're not getting that energy source. Most of the time, it results because of coronary artery disease, meaning build up fatty deposits in the walls. What we talked about, plaque. Those are the most common. Sometimes they can be because of other things, like blood clots. If you have a bad valve, like a bicuspid valve or something like that, that can create pockets where blood can actually clot in the chamber of the heart. And then as it pumps out, that clot can go into the coronary arteries. It can also go anywhere else in the body and cause an infarct in the brain, cause an infarct in the kidneys, like somebody that has AFib. Because they're not getting correct contraction of the heart, that blood will clot because it'll stay in the chambers and swirl and swirl and swirl. That creates an environment where blood can actually clot in the chambers. And then as those clots are pumped out, those clots can go anywhere in the body, right, that the heart's feeding. So it can go to the brain, cause a stroke, go to the heart, cause kidney failure, can go to the bone, cause infarcts of the bone. Those clots can go anywhere. And that's why anybody on AFib, we give blood thinner, so it prevents that clotting, because we know that if we don't, the blood will clot in the chambers of the heart and then it can be sent elsewhere. All right, heartbeat. So as we talked about before, there's a very coordinated manner in how the heart contracts. Let's see, 2 times. Okay. So these are the different types of muscle cells. The contractile cells, obviously, these are the muscles that actually contract. And then the non-contractile muscle cells are the ones that are conducting the electrical impulse to the contractile cells. And they control the coordination of how those muscles are going to contract. Let's see. So the contractile cells. These happen, the muscle contracts when there's calcium, right? Calcium is introduced to the muscle cell by an action potential. So that's the electrical system. The electrical system is all controlled by the sodium-potassium channels, and obviously is very, very fast. And once you get that electrical potential that reaches the muscle, it acts to control the calcium channels at the muscle membrane. The calcium rushes into the cell and causes the cell to contract. Because that calcium binds to troponin, and then the muscle contracts, right? So this is just a kind of graph and how it works. And the only reason why this is important is because it kind of helps you understand the flow of calcium and how the muscle depolarizes and then relax. So this is the action potential, very, very fast, and it's gone even as fast as it happened. But as soon as that action potential happens, it causes channels to open up, and it has to get to a certain threshold, and then boom, you get depolarization where calcium is at a threshold and the muscle can contract. Then as soon as it gets to about this part, that muscle starts to relax. And you start to lose calcium in the cell. And then it happens again until you get to your next action potential. And then it opens up those calcium channels. And as soon as those calcium channels get to a certain level, you get depolarization again. So this helps you understand with the ions. Calcium is all happening during this depolarization, right? Sodium and potassium channel leads up to the action potential, and then you get calcium influx. Then this is relaxation of the muscle. There's obviously a lot more. This kind of the surface understanding of how this works and how that electrical system hits that muscle to cause contraction. But you know, this is what you need to know. The rest of it is for, you know, research and drug development and everything else. From a physiology standpoint, treating a patient and understanding how it works, this is what we need to know. So the action potential is always happening with that calcium or the sodium potassium channels as they're going in and out. And when it gets to a certain or reaches the cell membrane, then it causes that calcium influx into the cell. Oh, this is just a sodium potassium pump, kind of an example. Sodium potassium pump is what creates the ATP with that exchange. It kind of feeds that action potential. This is a really busy slide. What you need to know is that when that action potential happens, opens up the calcium channels. Calcium channel, calcium ions are in the cytoplasm and rush and attached to troponin. And that's what actually creates muscle contraction. And then the calcium will leave again. And that will be the relaxation. As soon as the calcium leaves that troponin and is not bound to the troponin, the muscle can then relax again until the next contraction. So the contractile cells, as you can see here, this is the action potential with the influx of ions, and this is the actual contraction of the heart. And you see where it builds up to a certain threshold, you get calcium binding to troponin, causes depolarization of the cell, and that's when you get this rush of calcium into the cell, and you start to get contraction. That contraction builds to an apex where you have the most calcium, and then we'll start to relax again. That's where repolarization happens. The calcium starts to leave the cell. So yeah, we talked about this already. The action potential begins when the membrane is brought to a certain threshold. Let's see. We already talked about this as well. So we got entry of the sodium potassium channels until it gets to that threshold, and then starts that, opens up the calcium channels, and that's depolarization. Calcium enters, and then repolarization. So you get both calcium unbinds from the troponin, but you also lose, that's when you get potassium loss, and it goes back out. That's why hyperkalemia is so bad, because if you have too much potassium in the cell, then you don't have that flow of potassium out during repolarization, and the muscle cannot completely relax. And if a heart muscle does not completely relax, it's different from a skeletal muscle, where a skeletal muscle has phases. You can flex harder, flex really hard, and you can kind of control the strength of that. A muscle cell is all or none. It contracts and fully contracts, and then relaxes. And if it doesn't get to that full, or if it can't relax all the way, it can't contract. If it doesn't contract all the way, it won't relax. So it's all or none with the heart muscle. So if you've got too much potassium in the bloodstream and you can't get rid of the potassium because there's no pull, right? you've already got right? Because it kind of keeps it in this, can't relax all the way, kind of half contracted state, and won't allow it to get to the point where it can receive another action potential. Because it has to, in order to receive another action potential, it has to get back to this point. And if it's stuck here because it can't get rid of the potassium because there's already too much potassium in the bloodstream, it's stunned, it's kind of still, right?
I've just been commenting on this too. What I was saying is it's stuck in that contraction. It's already contracted once, but it's stuck.
Yeah, exactly. So it's kind of stuck in that period of, well, I'm not completely, or I've contracted, I'm trying to relax, I can't relax all the way, so I'm kind of stuck in this half contracted, trying to relax period. And I can't receive another action potential until I'm completely relaxed.
So is it kind of like a tetanus contraction where it's just all max contracting and it's not relaxing at all?
No, a tetanus contraction is like a full contraction.
Right.
You're like stuck in this phase almost.
Right.
So it's like a tetanus contraction, but it's kind of it's like in that in between state when you have that hyperkalemia. So you'll learn later in these courses how to treat hyperkalemia. We give insulin. Insulin pushes potassium into the cells. So we have to give sugar at the same time so that the sugar doesn't totally drop, right? So you have to give insulin and sugar. Calcium, we give calcium. One, because if we give insulin right away, or bicarb does the same thing, pushes potassium back into the cells. So if you give insulin and bicarb right away, it creates too much of a shift. If you shift too fast, that destabilizes the membrane. If you destabilize the membrane, then you don't have the correct flux, and then you stun the heart again. So the heart's already in a crappy state. You try to fix it, you put it into a crappier state. So before we even give those medicines, you have to give calcium. Calcium stabilizes the membrane so that you have a correct flux, and you can push potassium back into the cells. We also give albuterol. There's a lot of different medications you can give to push potassium back into the cells. You guys will learn all that later.
So you want to use that with like a normal safety type thing to have the sodium in there as well, or is the sodium not?
Yeah, well, you don't necessarily have to be giving normal saline to get all the medication. You certainly can, just to use kind of a buffer. But your intravascular system already has that composition, already has that same composition. So you don't necessarily have to give something with it because your body already has it. So this just talks about this kind of the speed, and this is a repeat of what we've already discussed. Refractory period continues until relaxation is underway. Prevents the summation of twitches that occur in skeletal muscles. So yeah, what we were talking about before, it has to completely relax. You have to have a complete refractory period before that muscle can contract again. Skeletal muscle is different. It doesn't have to completely relax, right? You can have different states and control that. It's voluntary. So yeah, in this regard, kind of like what your question was before, that refractory period avoids tetany, where you have a complete contraction. So automaticity. Automaticity is the electrical system of the heart. and basically there's a system where if one part of the heart goes out, you can still get heartbeats. And this goes along with a lot of electrical problems with the heart. When we talk about AV blocks, when we talk about left bundle branch blocks, right bundle branch blocks, it's all because of this automaticity. So it all starts at the sinus or the sinoatrial node or the sinus node, right? And it has a default setting that is going to set off those action potentials 60 to 100 beats per minute. That's the default setting. Then next is the AV node, and it also has a default setting, but it's lower, 40 to 60. So if the sinus node goes out, the AV node can still continue to cause the heart to beat, just not as well. If both of them go out, and you only have Purkinje fibers are in the outer part of the heart here, and we'll see better pictures a little bit later, but they can beat by themselves as well. So if the AV node and the sinus node goes out, Purkinje fibers will still cause the heart to beat, but just super slow. So you'll see this in complete heart block. You guys ever seen a complete heart block? When you're getting a patient, and maybe you didn't even realize it, you get a patient and they're unresponsive or whatever, and it's because they're bradycardic. You can still feel a pulse, but it's super slow. You're like, okay, how are we going to fix this? Sometimes it's because they have a complete heart block, meaning that AV node in the bundle cells is completely gone, and the only thing working is the Purkinje fibers. And so the heart is beating, but kind of sporadically and very, very slow.
Purkinje fibers, I mean, were they still contract the heart just as well as the sinus node, or are they weaker?
They'll still contract the heart the same, just slower. Yeah. And the pump won't be as good because the Purkinje fibers are out in the periphery, so they're not going to cause the atrium to pump first. It just kind of everything's going.
So the default setting is 60 to 100. If you want to rigorous exercise or something like that, fight or flight, it's going to raise it up.
Right.
So if you're in a full block, getting epi boosted up.
If you have a complete heart block, yeah, epi is not gonna help you like it would in if you didn't have an electrical conduction system. So epi will cause the sinus node and the AV node to increase those heart rates, right, and increase contractility. But if you have a complete heart block, yeah, epi is not gonna help you. So you can give it, but it's really not gonna do a whole lot. What you really need to do if you have a complete heart block and you have a heart rate there, I mean, people will be like, okay, well, they're on a beta blocker, let's give them atropine, let's give them epi, try to increase that heart rate. That's not going to do anything either. If you have a complete heart block, yeah, you have to pace them. If you don't pace them, you're not going to improve that.
Heart blocks are an electrical issue as opposed to like an infarct, which would be like
A muscle issue. Yeah. An infarct is because you're not getting blood supply to the muscle. A heart block is your cutting off the electrical system that causes the muscle to contract.
And what causes that?
Sometimes it's because of an infarct. Like if you get an infarct or you have a bad heart, you have too much plaque, and it kills some of the cells around the non-contractile muscle cells, so it kills the cells that create the conductivity of that electrical impulse, and you shut off that impulse at that spot. So heart disease. Sometimes people will have heart blocks anatomically, but most of the time it's because of the same thing, heart disease. Causing bad blood supply then kills the conductive system, which then affects the. So yeah, heart disease will affect the muscle in a lot of different ways.
That could also be brought about by.
What's that?
It can also be brought about the heart block can also be caused by.
Yeah, absolutely. Yep, absolutely. You get like severe hypokalemia can cause a heart block because you're not getting the electrical system. The Purkinje fibers will still, be trying to fire, but just not very well.
So when you get your first degree blocks, your second degree blocks, is that first degree referring to like the AV or the Purkinje fibers?
Yeah, first degree, second degree. That's pertaining to the sinus and AV node.
So the first degree block would be the sinus node is no longer working. The second degree would be the node is.
Well, it has to do with, yeah, so it's at mostly at the sinus node with, say, first and second degree blocks. Third degree blocks can be AV node as well. Well, third degree blocks is AV node as well. But so, and you'll get into this more when we talk about EKGs and stuff like that. But first degree blocks is a problem with the electrical system from the sinus node to the AV node. Because the AV node is what begins the ventricular contraction. The sinus node is what begins the atrial contraction. So if you have a problem in between there, you'll have a sinus contraction. The muscles are still connected together, so they'll still have a conductivity through, but you won't have that fast conductivity because there's a problem between the SA node and the AV node. So that the atrium will contract, and then there'll be a huge delay before the ventricle contract. And that's where you get that PR widening on the EKG. And then sometimes you won't have that connection there at all, and so you'll drop a ventricular contraction. You'll see the atrium contract, you'll see the P wave on the EKG, there'll be no QRS. So there's no ventricle contraction. And that's because of that connection between the SA node and the AV node. Make sense? Clear as mud? And you'll learn about that stuff later. You don't have to know about AV blocks and stuff like that now. It just helps you understand why we need to know this stuff. Conducting system, so yeah, so this is just more definition of automaticity. You don't have to have stimulation. Your brain doesn't have to tell you your heart to beat. Your heart will have a default setting, and those things will continue to fire regardless. So that's why people are brain dead, and but you want to preserve their organs. And you know, a person who's a vegetable, they're never going to wake back up from their coma. They're brain dead. Their brain is done, but their heart keeps going. So it supplies blood flow to the rest of the organs, and everything else keeps working, even though the brain's not functioning. So yeah, there's a precise sequence, and when that sequence goes off, that's when you start to get different blocks. That's when you start to get blood clots. You start to get a lot of different things when you don't have the precise sequence. So atria contracts, obviously, just before the ventricle does. Push blood into the ventricle, and the ventricle contracts, pushes blood up either to the lungs or to the body, right? So that network of cardiac muscles initiates and then distributes that electrical impulse. And we'll see, there'll be a picture later on in the slides that will help you understand that a little bit better. So this is the sinoatrial node, right at that atrium. So it goes off at that preset default settings, right? So that atrium is always going to contract, and then it sends an electrical impulse to the AV node, which is obviously super fast because it's a direct connection. If these things are broken and there's no connection to the AV node, well, the muscles of the atrium still contract. They're connected to the muscles of the ventricle. You'll still get a conductive system through the muscles. It'll just be a lot slower. That's why it takes that precision away. And same thing here. This is working, but you block these bundle branches. They're coming down from the AV node. Bundle branches are going to the Purkinje fibers, which are here in the outer rim. If you block those bundle branches, so you get a left bundle branch block, and then that becomes a lot slower, so it causes that contraction to be a lot slower, so it widens that QRS, right? That's why in a bundle branch block, that QRS is widened. It's because that electrical system isn't as fast, and it has to wait for those connections through all the muscles. All right, now the Purkinje fibers, even if both of these are cut off, you have a right bundle branch block and a left bundle branch block. That's called a complete block, or a third degree block. All you have is the Purkinje fibers firing, and that's why it's so slow, because their default is a lot lower. And if only these things are firing, then the whole thing is slower, and you get contraction in a uncoordinated manner.
Does the atrium contract at all?
It depends. So as you get this bundle branch block, it's preventing quick contraction to these, but yes, the atrium is, you're still going to have few ways the atrium is still going to contract because the AV node's still going. And that's why you can see on the EKG on a third-degree block, the P waves and the QRS are completely discoordinated. So you'll see P waves going off at that sinoatrial default, and they'll look completely regular. We call them marching out. Those P waves are marching out. You see those P waves just go do, 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 but there's no QRS. That ventricle is not beating with it because the Purkinje fibers have no connection to the sinoatrial node because you have that block right there at that bundle branch block, so the Purkinje fibers are going on their own set. So Purkinje fibers are going at 20 beats a minute, 30 beats a minute, while the atrium's still beating at 60 beats a minute.
So you'll see a QRS complex just randomly.
Yeah, you'll see, exactly. You'll see QRS complex randomly scattered, not following the P waves at all. Where normally, QRS is always after the P wave, right? Because of this electrical system. But if that electrical system gets messed up, especially with a complete heart block, they both beat independently. But you're only getting blood flow with ventricles, right? If the atrium's beating along, but the ventricles aren't working, you're not getting blood flow. That's why complete heart block, those patients will become unresponsive because they're just not getting the blood flow.
So if like a left bundle block, does the right ventricle beat normally?
Yep, right ventricle keeps beating, and the left ventricle has to wait until they get that muscle connection. That electrical system goes through the muscles before it'll beat. So that right side will beat way before the left, and the left will be really delayed.
To get that, that's kind of like a CHF type thing?
Or
Does it just push out more volume?
It will. So CHF is when you get dilation of the heart, and you don't get very good contraction because the muscle's so dilated. The muscles are farther apart. It's really hard to pull those muscles together and get a good contraction. So you get dilation of the heart. And yes, that can happen with left heart strain, right heart strain. So dilation of the heart happens because blood flow going out of the heart, there's too much resistance. It's not an easy pump out because somebody has hypertension. So all of their arteries outside of the heart are contracted. They have plaque buildup in all of those arteries, so it's really hard to push blood through all of that stuff. So it makes the heart work really hard. That contraction has to work really hard to get blood flow, and then you get this resistance and backup, and the heart starts to stop contracting very well, right? And then it becomes dilated. And that contraction gets worse and worse if it's pumping against too much resistance. Does that make sense?
So an acute bundle branch block would happen pretty quick where the fluid back up from the right side pumping fast enough.
Yeah, so the right side's still pumping fast enough, the left side's delayed, and yeah, you will get a fluid backup. An acute left bundle branch block is a heart attack until it's proven otherwise, right? You'll get fluid backup and oftentimes in their lungs, so they'll sound wet and they'll sound like they're having a CHF exacerbation. And the wife will be like, he's never had a heart problem before, they've never told me he has congestive heart failure, because he doesn't have a dilated heart yet. Because that's if that's an acute block, then you get acute backup, and the heart's not ready to deal with that. Okay. Nope. Any other questions? All right. We talked about this conducting system, nodal cells. They depolarize spontaneously. That's automaticity. We talked about that. Each muscle is electrically coupled to each other, and that's why the muscles can still receive that electrical impulse even if the conducting system's out, because the muscles are connected to each other. It's just slower and delayed.
So back to the right and left blocks. Do the right ones have influence on the left ones? So you've got the left side block because it still gets some.
Yep. So those muscles will still be connected, and you're still getting electrical impulse to the rest of the heart, but it'll be slower because it has to go through all the muscles instead of being, through the electrical system. This just talks about ions. All you have to know is really that you have an influx of calcium during depolarization.
Is that big ions?
Yeah, that's ionized calcium. Yeah. And this is basically inside the cell and outside the cell. And the threshold is you have to get you have to reach a certain threshold before that action potential can happen, and this is contraction. When you get enough calcium in the cell, then you boom, you get contraction, and then it starts to relax again. Let's see. But it's important to know that the action potential starts with the sodium influx, and that opens up the calcium channel. And then once you get enough calcium, then you get contraction of the muscle. But the action potential is because of that sodium potassium channel. Specialized. Oh yeah. So this is the muscle can depolarize without any external influence, and that's the automaticity, meaning that it has a default setting, so you can just keep going. Brain doesn't have to tell it to pump.
That's a turtle.
Yeah. This just talks about the net charge that we've already talked about. Coordinated contraction, we talked about that. So the nodal cells, or the SA node, is the pacemaker for the heart. And that's the sinoatrial node. We talked about that. The automatic pacer of the heart is at that sinoatrial node. I should have probably left out some of these slides because it's repeating. So with the SA node, you just have to know it depolarizes spontaneously. And it generates, at default. And this says 70 to 100 or 70 to 80. We've talked about 60 to 100 before, but that's the default setting for the conduction system. So this just talked about, so with the correct process for contraction, the atria needs to contract before the ventricles. Obviously that makes sense, right? Because they have to push blood into the ventricles. If they don't contract that way, then the ventricles are not pumping blood effectively. And it's important to know that the ventricles contract together. They begin at the apex. So they begin at the end of the heart down here. And that's why that conduction system goes all the way down to the end with the Purkinje fibers. And so this atrial will beat, but this part of the ventricle is not going to beat first because this electrical system is going to get down to these muscles before. And the contraction starts at the apex. Why do you think the contraction needs to start at the apex? Right, squeezing the blood up. That's that twisting motion that we talked about. So we know SA node is connected to the AV node. AV node has its own action potential. It has a default setting if it's not stimulated by the SA node. So yeah, we talked about that before. If the SA node goes out, it kind of goes in order. If the SA node goes out, well, then the AV node is going to keep beating at its certain pacemaker. If the AV node goes out, then the Purkinje fibers are going to beat at their own.
So when you get elite athletes that have their heart rates lower, resting heart rate 40s and 50s, is that an okay thing, or is that more? Yeah,
it means that. So because the SA node is the pacemaker of the heart in any healthy individual, there are different effects from the body that will slow the heart rate down, raise the heart rate up, and it'll stimulate the SA node. So in an athlete that has a super efficient heart, it doesn't need to pump as much blood because its heart is so efficient and pumps so well. It's not pumping against any resistance because there's no plaque buildup in the rest of the body. And they've got such good return because all of an athlete's muscles are working so well that there's also very good venous return and preload. So it's filling the heart back up appropriately. So it just doesn't need to work as hard. And there's certain chemicals released in the muscles, certain chemicals released to the kidneys that says, hey, I'm getting plenty of flow. And it'll send a signal up to the SA node through certain hormones and tell the SA node, hey, you can slow down if you want because we don't need it. And that happens in athletes. Same thing when people are in bad shape. Hey, you need to squeeze harder. Hey, you need to go faster. Whatever. So a lot of obese patients, they sit at a heart rate of 100, and their heart needs to work harder. Over time, that's going to wear out. Bundle of His is basically just where the AV node is, and then that divides into the bundle branches and down into the Purkinje fibers. And we showed in the picture where those bundle branches go. They're on the inner surface of the ventricles and go down into the Purkinje fibers. These are specialized nerve cells, or I should say non-contractile muscle cells. Because all of this conductive system, these are specialized muscle cells, non-contractile muscle cells, not necessarily nerve cells. So this just talks about how fast they are from the SA node to the AV node.
What was it back and forth? You said the different bundles and that. You said they're actually muscle cells.
Yeah. So the conductive system of the heart, there's two different cells of the heart, and there's contractile muscle cells, and then there's non-contractile muscle cells. Non-contractile muscle cells are what's conducting the electrical impulse. We talked about this already, just how the SA node, this kind of gives you just a visualization of when the SA node goes, then the atrial contraction starts, but it also sends a signal to the AV node, and that's quick. This goes into the dissection of the muscle cells themselves. Like this is one cell, this is one cell. Each cell has its own nucleus, and then if you break that down, then you have gap junctions that create connections between the two muscle cells, and that helps. That's where the electrical impulse comes from, or is communicated, is through the gap junctions. So yeah, electrical current starts there, and then it goes through the muscle cells, right? That's pretty.
So is there a nerve impulse there that helps control it as well, or is it all just?
It's all automaticity of the muscle cells of the heart. So this just talks about the action potential when it actually creates that stimulus to cause a contraction. So it just says how the SA node affects the contraction that atria first. You guys don't need to memorize speeds at all. But it just gives you, I guess, an understanding that there's a delay between the atria and the ventricle contraction, which what we talked about before, and the need for that. And then this talks about the action potential of the AV. Continues down that intraventricular system through the bundles, and then it spreads out through the Purkinje fibers to cause that contraction from the bottom up. So EKG, this is recording that electrical impulse, right? So even if those impulses are out, we can still get a recording of the electrical system of the heart because the muscles are still contracted. So this just kind of gives you, so this is an EKG, or this is what would show up on an EKG, right? You've got a P wave, which is the contraction of the It's actually the beginning of the SA node, starts the P wave, and you get a contraction of the atrium, which is atrial depolarization, which is the P wave. And during that, I mean, that signal is so quick, while the atrium is contracting, you already get a signal to the AV node, says, okay, the ventricle needs to contract, boom, and then you get a QRS. And then as that ventricle and or if that ventricle is relaxing, you get a repolarization. During the ventricular depolarization, the atria is already relaxing, but you don't see that because it's hidden. The ventricle activity is so much stronger than the atrium relaxing. You just don't even see it on the EKG.
Spaced out, you still don't see the depolarized.
Right, yeah, you still don't see it. It's because it's, I mean, that electrical stimulus is so so small that you don't see the repolarization. Oh yeah, that's fine.
Which slide?
Oh, which slide? Let's see, 92. We can probably go through. We already know some of this stuff. You guys will learn about this later, but this is a normal PQRS. This is when you have a left bundle branch block. This is when you have a right bundle branch block, and this is at V1. So left bundle branch block looks kind of like a W. Now, it doesn't always look exactly like that. Sometimes it's like, well, is that a W? I don't know. But if you have a wide QRS without a wide QRS that's not tachycardic, it's a bundle branch block, right? If you have a wide QRS and tachycardic, well, that's V-tach, and that's treated a little bit different way. But if it's not tachycardic and it's wide, then you've got a bundle branch block, and then you can see, well, is that a left bundle or is that a right bundle? If it's a left bundle, and they've never had it before, well, this could be a heart attack. So this is just an example of if that signal goes through the conduction system super fast. If the signal is through the muscles, it's slow and delayed. That's why you have a wide QRS. This just goes along more like a left bundle in V1. And so you can, like I said, it doesn't always look like a W. But if you have a strong S wave, which is that downward injection of the QRS, and then you have a strong R wave in V6, it's left bundle, and it's opposite the right bundle. EKGs, that'll be January. I think we'll go through all that stuff in detail. We did this. Okay, two phases of the cardiac system. You guys understand systole and diastole. Systole is the contraction of the heart muscle, right, where the chamber's squeezing. Diastole is a relaxation. During diastole is when it's filling with blood and preparing for the next contraction. It's a high-pressure system. Obviously, the pressure is a lot higher in systole. Diastole, that pressure is certainly lower, but it still has to have a certain pressure in diastole to be effective. This is just a picture that helps you understand the different chambers in diastole and systole. So, atrial contraction, systole. Then, as soon as that atrium is done, it's relaxing all the way diastole until it's ready to beat again. And during that whole time, ventricle is in systole and contraction, and then relaxing at diastole. I don't think this part. I guess if you want to understand the flow of the blood is good, and where it's all going. So let's talk about the heart sounds when you're listening to somebody's heart. What's the first sound? Where's it coming from? Right. So that's the AV valve, right? So that's after the atrium has already contracted and it's pushing blood down into the ventricle, and then that AV valve snaps shut. That's that first sound. And then the ventricle contracts, pushes blood out to the lungs and to the body, and then the pulmonary valve and the aortic valve snap shut, and that's the second sound. So in between those two snaps is systole, is blood pushing out into the body, right? And the rest of it is diastole. So if you hear a murmur after the second sound, that's a murmur during diastole, and you can figure out where in the heart that murmur might be, depending on where you're listening. If you hear a murmur during systole, depending on where you're listening to the heart, you can tell where the problem is. Well, that's a mitral valve problem. That's a, whatever. And that's why it's important to understand what valves are shutting and what valves are opening during those two heart sounds. The second heart sound can sometimes be two, right? So you can get kind of a dum, 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 dum. And that's because the aortic valve and the pulmonary valve are snapping shut at a little bit different times. And that can happen if you have right heart strain, left heart strain. One of them is shutting before the other because the other one's still trying to squeeze more blood. It's not working as well. Third and fourth heart sounds really hard to hear, but that's the contraction of the atrium into the ventricles, and oftentimes you can't really hear that very well. They're super faint. So now we're going to be talking about the basically cardiac output. Stroke volume is the amount of blood from the ventricle, right, pumped out. The cardiac output is the amount of blood from the ventricle over a minute. So the cardiac output would be the stroke volume times the heart rate. So however many times it beats in a minute and how much volume it got out in that. So really all you have to know is cardiac output is heartbeat times stroke volume. And if you increase or decrease either of these, that affects your overall cardiac output. So yeah, this is what I'm talking about. It's variable because heart rate and stroke volume can increase or decrease because of certain situations. And your cardiac output can increase to up to 500 to 700 times its normal, depending on the situation. So major factors affecting heart rate and stroke volume is blood volume reflexes, and we'll talk about that. The autonomic innervation, so sympathetic, parasympathetic systems, telling you how to, how fast, how hard to contract, and then hormones can affect it as well. Let's see. Why don't we take a quick break? You guys can get up, walk around, get a drink, and then we'll finish with the heart and the dynamics. All right, we ready? Get through this. We got about 20 more slides until the end of this one, and we can take another quick short break. And then the next one's not nearly as long. The heart is kind of a big one. So the two things from this slide I think that you need to understand is that contraction is an active process, relaxation is a passive process. So there's nothing actively causing the heart to dilate other than blood coming into it to stretch it back out. So in order for it to contract again, like I said, you have to get the right stretch. So blood has to be pouring into it. Blood volume reflexes, obviously there's a direct relationship. The amount of blood entering the heart, the amount of blood ejected with the next contraction. Two reflexes respond to the changes in blood volume. So the right atrium reflex has to do with the heart rate, and the ventricular reflex has to do with the contraction or the stroke volume, how hard it contracts, how much blood it can push out. The atrial reflex is also called the Bainbridge reflex. It adjusts the heart rate depending on how much it's stretching. So how much preload it's getting stretches that atrium out and tells the heart to increase or decrease the heart rate. If it's stretching too much, it means that it's filling too much. There's too much space in between the heart rate, so we need to bump up the heart rate. So if it feels more stretch, it'll increase the heart rate. If it's not stretching enough, it'll decrease the heart rate. It says, oh, we need a little bit more blood here before we contract. So it's constantly adjusting depending on what your return is. We just talked about this. The sympathetic stimulation acts on the SA node. So when you give a patient norepinephrine or epinephrine, it increases the heart rate, right? It's sympathetic stimulation of that SA node. Stroke volume.
Is there nerve connection to the SA node then?
Yeah. And we'll see this. We'll see where it's connected. So there's a sympathetic connection and a parasympathetic connection, and they go to different nodes. So stroke volume depends on how much blood is inside of it, right? So how much venous return it has and how much time it has to get that venous return. The filling time is diastole, and that is dependent on the heart rate. If you have a slower heart rate, you have an increased diastole, you're going to have increased fill time. Higher heart rate, you're going to have decreased fill time, and your stroke volume is going to go down. So this is all called the Frank-Starling principle. This is the physiology of the cardiac output of the heart. Basically, it is the more in, the more out. All right. This goes into kind of better detail. So Frank-Starling principle is all dependent on the volume that enters the ventricle. The power of the contraction gives the greater stroke volume. So more filling time, more powerful contraction equals greater stroke volume. But you're going to have better cardiac input. So venous return increases, the ventricular myocardium stretches, and it tells, as soon as the ventricle stretches, it says, oh man, I got a lot of blood. That tells the heart, I really got to contract down. So the more stretch gives the stronger contraction. All right? And that's just a graph to explain the same thing. Autonomic innervation. So the SA node pacemaker cells have a basic heart rate, what we talked about before, but it can be modified by the autonomic nervous system, both sympathetic and parasympathetic. And this is where we have those connections. So this sympathetic is on this side, and it is going right here to the SA node. This is the fancy name for the cardioacceleratory center. Basically, comes from the brainstem, has that sympathetic connection. You also have sympathetic preganglion fibers from the spinal cord, and that also has connectivity to the SA node and to the rest of the heart, and giving signals to increase or decrease either contraction or heart rate. And then the parasympathetic system comes from the medulla oblongata. Here's from the water and the vagus nerve. So it gives a signal to the parasympathetic, and the parasympathetic would do what? If it was stimulating the heart, it would cause the heart to decrease its heart rate. Exactly. So acetylcholine is released by the parasympathetic motor neurons, lowers the heart rate. Norepinephrine is released by the sympathetic neurons, it increases the heart rate. All right? Acetylcholine decreases it, associated with parasympathetic system. The norepinephrine and epinephrine increases it, associated with the sympathetic system. Sympathetic system is fight or flight, right? So that's where your norepinephrine is going to go. Parasympathetic is rest and digest. It's going to decrease your heart rate. So sustained increase in heart rate, right? Epinephrine is short-lived, fight or flight, but then you're going to slow down again. If you want sustained increase in the heart rate, that's going to come from consistent release of epinephrine or norepinephrine from the adrenal medulla. So the kidneys are going to know if you're getting enough blood flow. If you're not getting enough blood flow, they'll be like, all right, let's increase this heart rate. Let's increase this contraction. Let's get some more blood flow because the rest of the body is just not getting it. So there's a couple things that are working on it. The heart itself will monitor it just based on the Frank Starling, right? And then, but the rest of the body is going to say, hey, we don't have enough or we have too much. So it alters the force of the contraction as well. So if you block the vagus nerve, that's blocking which part of the autonomic nervous system? Vagus nerve, if you're blocking the vagus nerve, accidentally cut it for whatever reason, blocks the parasympathetic system and your heart rate will increase. You block the sympathetic nervous system, and that'll slow down the heart rate. That can happen. Tumors, a very common tumor is a Pancoast tumor in the chest, and that can block that sympathetic nervous system. And then vagus nerve is usually because of trauma. You block that vagus nerve, and it'll increase that heart rate.
So that's why you get people go down when they're straining on the toilet. They're
We'll talk about that later. Bearing down is a vasovagal reflex. But right, when you do the vasovagal reflex, you're stimulating the parasympathetic nervous system, decrease the heart rate. That happens, yeah, people bearing down. Massaging the carotid artery can cause the same thing. That's why, people that have SVT and their heart rate's going crazy, we want a quick stimulus to that SA node to say slow down the heart rate and kind of reset, right? So that's why you'll see sometimes vasovagal reflex can happen from sudden cold. So you throw a bag of ice on somebody's face, or you jump into an ice cold lake and you kind of freeze and it takes your breath away for a second. Well, that's also your body resetting your heart rate. Telling somebody to bear down, take a big deep breath, bear down, that also affects the parasympathetic nervous system. That's a vasovagal response to decrease the heart rate. Let's see. So part of that is the baroreceptors and the chemoreceptors. The baroreceptors is the pressure. And that's why you can massage the carotid, because you change the pressure on that carotid artery right where that sensor is. And it kind of tricks the heart into thinking that it's beating too much, so it'll slow it down. And baroreceptor with bearing down, when you bear down, that increases your intrathoracic pressure. And that tells the heart, hey, we've got too much pressure, we need to slow down as well. But chemoreceptors are connected by the glossopharyngeal nerve and vagus nerve.
Can that work in like a panic attack type of thing too? Somebody's having a panic attack and their heart rate's jumping way up there. If you get them on carotid massage, that can help.
No, because the panic attack and the heart rate increase is an oxygen CO2 problem. So you have to fix that diffusion first, and that's why the paper bag works, is because they're blowing off too much CO2, right? In a panic attack, you need to slow down their breathing. In order to do that, you decrease the amount of CO2 that you're losing by making them breathe in a bag, so they breathe back in the CO2 and kind of fix that respiratory problem.
Is that something that would be useful on an ambulance? Like if we give them like an innocence bag or something like that, breathe into?
If they're having a panic attack, yeah. You just have to be careful, because the joke that one of my trainers, one of my attendings used to tell me in residency is like, you know what, you'd be anxious too if you were having a heart attack, or you'd be anxious too if you had a PE or whatever. So you just have to be careful, because anxiety can obviously mask a lot of other things. And you know, if they're having a PE, you don't want to give them a paper bag and lose their oxygen, right? So the autonomic activity is directly affected to the oxygen and carbon dioxide in their bloodstream. So kind of in summary of all of this, these are the things that I want you to do, and we'll go through some of the summary. So describe the location and features of the heart. That's basically what we already did with the atrium, ventricle, and all of that. But that third part, describe the components of the conduction system. So where would you have innervation? About right here in the atrium. Which node is that? SA node, and it comes down here to the AV node. It can also be called what? Bundle of His. Good. And then you're coming down here in what? Bundle branches, and then you're coming out here with Purkinje fibers. Perfect. And the fact that that can all happen by itself without any is called what? Automaticity. Good. We talked about the blood flow of the heart here. Does anybody have any questions about that? With how it works with the pulmonary system and the body? All right, good. Conduction system functions. We talked about that. Cardiac cycle. Okay. Contraction of the ventricles happens where first? Which part of the heart? At the apex. Good.
The bottom part is about the apex.
Yeah. So yeah, the heart will kind of be shaped like that, right? And this is the apex. The apex of the heart is about right there. So when you're listening to it, you can hear that. Factors that influence cardiac output. So cardiac output is what? Your stroke volume times your heart rate. What are factors that can affect your heart rate? So autonomic nervous system, right? Where the two branches of autonomic are sympathetic. Okay, good. Chemoreceptors for parasympathetic. What is gonna stimulate the parasympathetic system? Acetylcholine. Good. What is gonna stimulate the sympathetic nervous system? Epi and norepi. Good. When the atrium stretches, how does that affect the heart rate? If it stretches too much. What's that? And slow down. Good. And then what happens if the ventricle stretches too much? It's not going to. If the ventricle stretches, it's not going to affect the heart rate. It'll affect what? The contraction. That just tells how hard it's going to contract. That's called the Frank-Starling, right? Is that if you get, the more you put in, the more you get out. So the more that ventricle stretches, the harder it's going to contract, and the more it's going to push out.
And the atrium, you said if it fills up too far, it'll slow down. Or
Yeah. So if the atrium stretches too much, it tells the heart that I'm getting too much blood. That means that there's too long of a delay between heart contractions. It's too much filling time. So it'll increase the heart rate to decrease that delay between beats, right? Does that make sense?
yeah, Bainbridge reflex.
Bainbridge reflex is the atrial reflex. Yeah, that's called the Bainbridge reflex. The ventricular reflex is, you can call it the Frank-Starling principle. Let's see. It's a good summary. Anything else? Anybody have questions on anything? How it all works out?
What was it come up with the parasympathetic system?
Acetylcholine. Acetylcholine.
Thank you.
And you'll see that throughout. I mean, in all the organ systems that you guys study, how acetylcholine and epinephrine or norepinephrine work on either the sympathetic or parasympathetic system. All right. We're good. So that's why, like, just like a quick note, you know, pesticide poisoning, organophosphate poisoning, you know, some of those will inhibit acetylcholine, right? If you inhibit acetylcholine, what happens to your heart rate? Yeah, it's going to speed up. Person starts to have kind of a sympathetic overload, right? There's no acetylcholine to control the other side of it. And then there's also different drugs that'll stimulate acetylcholine, and everything will slow down. You know, you get people, that sympathetic response will be that, you know, drooling, heart rate slow, feeling tired, kind of picture. But we'll learn about those different effects later. But all right, you guys take a quick break again, and then we'll start up.
Just call it be back at noon. 7, 8
What's that?
minutes. Start at noon.
Yeah, we'll start again. We'll start again at noon. Gary, do you usually have them like eat in between one of these, or
No, not for today.
you just go through it and just get it done? All right.
That's full time.